And are we doing anything to track that patient has been able to find another physician or has gone to another physician, referring to the scenario you shared a while ago, and determining where is that patient as far as getting their medical attention once they make a decision to leave? Are there any tools to show how many are falling through the cracks or leaving and not picking services up until they show up at the ER somewhere else?
In our primary care medical home program, the way Medicaid runs its primary care, every patient has to have a primary care physician. So if they leave one physician, they get picked up by another. We can track that.
Do you see a lot of changing going on like that?
I haven't done the analysis. There's always some baseline movement going on, and but I'd have to do a formal analysis, and I'm not sure we've done that. I'm not hearing stories. I'm not hearing issues, but we always have to check those out.
Thank you.
President Gray, you recognize.
Thank you, Mr. Chair. I guess I'd like to reiterate what Senator Irvin has said. In our world, my husband's a primary care family physician, and in our world, the two are completely different: episodes of care and the patient-centered medical homes. And I think everyone here has heard me talk about the patient-centered medical homes and what a wonderful program that is. We don't make any money off of it currently. The money, the per member per month fees we get go directly to hire a care coordinator. And what we've seen in our patient level of patient care, the follow-up, discharge summaries, keeping them out of the hospital has been amazing. Not only I think in cost savings, but in actual quality of life for our patients. The episodes of care, what I worry about, and what I've actually talked to some of my colleagues here about, is we're so overregulated as it is, and episodes of care, like for my business, we have to go in and enter stuff in the website, do all this for ADHD. I think we made $40 last year. I mean, it's not even worth us, opening up that web page. And out of, we talk to physicians all across the state. I think I found 2 that actually like it. Everyone else, they all hate it. It's cumbersome. They don't feel like they're getting to treat the patients the way that they should treat them because it's punitive. There's such a shortage of primary care physicians already. If we continue down this path, I see an even greater shortage coming in the near future.
So when we did the initial episodes of care, again, we had a blank page, and we wanted to at least get some proof of concept. So common cold, to some extent ADHD, though primary care ADHD has been fairly modest in terms of our expenditures. We had subsequently developed the medical home program, and it's very clear to us that the medical home program is the way to go with primary care. So episodes of care for primary care really does not match up well for the medical homes. So we're going to take most of our activity and attention to the medical home program and not episodes of care for primary care.
Okay.
And I think just to build on that, that was a commitment that we made certainly with the medical society as well as with the legislature as part of this most recent session, is that any new episodes going forward would not have the primary care provider as the lead provider in those situations. Certainly it may still include like an emergency room physician or others, but it won't be the primary care physician.
Okay. And one final question: how do the specialists, feel about how the orthopedics feel that this program is working?
All I can tell you that the ENT docs, when we work with them for consulting, they're very engaged and enthusiastic. We have not had, we just had some town halls. We've had very little complaining. We've had very little folks poking at it. We've had surgeons involved. They have been very constructive in their comments. We're trying to make the program as outreach and be responsive as possible. As I said, we're trying to be a learning system where providers and the payers learn from each other. We have not had, not everybody will be happy, but most providers are happy. We have a couple of episodes here and there where we talk with individual providers, and when we go over their data and go over their access, things are kind of better received, because I think we have to get used to how it works. But for the most part, We have not had serious flashpoints, and we have seen, for the most part, you can ask David Roten and the Hospital Association. I think the vast majority have been satisfied, and so I think
They're going to be speaking here in a minute, so we'll be able to start.
I think the issues are not that too dramatic.
Okay, and that's one of the things I'd like to see is almost like a or a physician satisfaction survey, because I know probably what goes on here at UAMS and at Little Rock is completely different than what happens in our rural world where we struggle. It takes us a year. If we have an orthopedic surgeon, it's a year or 2 years before we can recruit one. So I think, I just like to see the numbers and like to see the difference between rural and urban.
And I know that's actually the Stevens Group did a survey, I think they're gonna talk more about that today as well, but I think in terms of with some of the specialists, one thing that we hear, from some of them has been, I think that these types of initiatives offer a chance to differentiate themselves, perhaps from some of their peers in terms of when, and I realize it's not the case necessarily in the rural areas, but I think in other areas, I think to say, yeah, you've got a choice of 2 or 3 in the area, I want to be able to show you why I might be the best choice for you when you're having to think about referrals and those types of things. I mean, it's a good point. That's obviously an area we need to continue working on, is how do we make sure that we're best meeting the needs of our rural providers and helping support them with these types of initiatives. But it is a great way, I think, to be able to differentiate for folks who really want to take advantage of the program and see it as an opportunity to be able to succeed.
And follow up, in terms of the overall concept of episodes, as opposed to alternatives that are out there to manage costs, most of the physicians and the leaders are happy. The implementation, you can get into debates about, should it be this exclusion or that exclusion, we have discussions. And I think also we have the limitations of data right now, and sometimes we have to get anything quality, tell people that they can put data into the system. As our EMRs get better and we can extract data, we can reduce that. So obviously we are dealing with halfway technologies right now, but we want to make the program as least burdensome as possible. So we hear what you're saying, we agree, and the program will evolve, but we want to reduce those kind of burdens as much as possible.
And I think looking for those opportunities where, one thing that we've been kind of throwing around has been, and I think there's many more examples like this, and we certainly, appreciate feedback from providers on this as well, is, let's say, for example, you have a provider who has been doing well for a couple of years in terms of they've reached the commendable thresholds in terms of they get shared savings, they've been able to quality metrics. One thing we could look at, I think other programs have done this as well, to say, for the next year, you may not have to enter your metrics. Instead, we might look back and do a sample of 15 cases or whatever it is, and see whether or not you're still meeting those metrics. But to your point, to say, for providers who are doing well, they're doing what they need to be doing, chances to be able to reduce some of that administrative burden while still allowing them to excel in the program.
Okay, and let me just remind everybody about this Don referred to the survey. I think Stephen Group said they had 250 physicians respond to that, which is not very many. So the first thing I want to ask a physician when they give me my input or their input about their thoughts on this is, have you filled out the survey yet? So we've got to get the word out to our physicians that if they want to be heard, they're going to have to fill out a survey. Same thing, we're sending teachers in the survey that the PSE is doing. So hopefully we can use whatever means we have available to make that happen, because we do want to know. As I said, I was surprised by the results of the survey based on some of the things I hear down here in Little Rock. So I hope the folks will fill those things out. We've got 3 more on the list here, and again, I remind all of us that we've got 2 or 3 more groups to speak on this topic. So if it's a question that's going to be better answered by the Stephen Group, or by the Medical Association, by the Hospital Association, let's take Senator Irvin, your recommendation.
Thank you. One of the answers you gave to Senator Bledsoe was the changing, and I'm concerned about that because, when you have an incentive, you're basically, one of the complaints or one of my problems is this is a back-end reconciliation. So you're not really seeing your behavior in real time. So you're saying that that's a changing. So the threshold is always changing based on the community that you're in. And then how would that evolve into a real-time scenario to where they can kind of track to see whether they're meeting those standards or not, to where then they would then say at the end, instead of a back-end reconciliation, that you did well or you didn't do well, is there any opportunity for them to see the data of their peers in a real-time setting? Because that's one of the concerns I hear a lot.
We designed the program to the best we can about that concern. We started the program, people received a baseline report of their previous year's activity. And then they had 90 days to respond to it before they were accountable for future costs. We provide quarterly report cards. It's not instantaneous, but every quarter they can go and see a report card that shows their costs, their peers' costs, their quality metrics, how the money is being spent on their patients. We have on a portal. We have displayed this to other Medicaid meetings. Other states are extremely envious.
And that portal is through AHIN, correct?
It's direct, that's
And
correct.
that has to be paid for. The provider has to pay for
No,
it.
it is
Yes.
not.
No, yes, you have to pay for it to AHIN now.
I think just to,
You have to, it's not free anymore.
Right, I think just to clarify, as I understand it, Blue Cross can best speak to this, I believe that for some services within the portal, you do have to pay a subscription for that. I know that for access to these reports, I think to get information about episodes of patient-centered medical homes, that is not something that, to our knowledge, that providers have to pay for, but that's probably best to be addressed by Blue Cross.
Okay, so it's a back-end reconciliation, correct?
Well, you accumulate costs over time, and so then we look at your year's performance and do reconciliation based on your previous year's activity, based on your actual costs and cases.
And I think to your point, I mean, that's something we'd love to get to. I mean, I think that's one of the things, you know, we've talked a little bit about the new Medicaid Management Information System, MMIS. I think that will allow us to be able to do more real-time reporting and provide information to providers. At this point, I think even though it's still a little bit behind, you know, I think the quarterly reports that we give to providers, you know, on both of these particular payment reforms, I think it's helpful in terms of your point. They don't have to wait till the end of the year. They can look every quarter in terms of what's happening, what am I doing, what are my peers doing, you know, and where there may be opportunities to improve.
But the key thing is that the reconciliation is not based on each case you do, but based on your average of multiple cases. So, you know, if you have one funny case, you know, you're not necessarily penalized. It's really the average of what you've done over the year.
Yeah, and I understand that, but final question. Do y'all handle the appeals, or is that a different department?
We do.
You do. So there are current appeals right now?
Yes,
correct?
we have a few appeals that we're working through.
Okay. And then final question. On your total joint replacement, the infections and the complications, y'all increase that. I keep going back to that, because do you have any data as to how much those complications and infections cost? Because the complications, that's a pretty large increase right there, from 6.4 to 7.9. And those are, with a total joint replacement, those are significant, they can be very significant, which could result in another total joint
Yes.
replacement. So,
There would be, given the small number of cases, that increase would reflect probably one case difference year over year. So it's hard to make a statement about, you know, one or two case difference year over year as to be a trend reflecting the program or just kind of random activity.
right, my concern would be denial. Like, if, one thing that we discussed yesterday with pharmacy is the fact that a limited number of prescriptions for Medicaid patients sometimes is not in their best interest. We may think that we're saving money on the front end, but limiting certain cases of prescriptions really results in higher expensive care. And that's one of my big concerns with episode of care, is that there is an opportunity to deny care to meet those thresholds that may result in larger expenses down the road that we're not accountable for.
I think it's an important point. I think a couple things on that. One, you know, I think with the episodes, and I think Dr. Bull talked about this as well, I mean, you know, we're not saying that you can or can't do something. I mean, in fact, actually, when you look at a number of the episodes, we've actually removed the prior authorizations from a number of those services in terms of, that way, you know, if you have a client, you have a patient, or maybe a handful that are very difficult to treat because they have complex conditions or whatever the case may be, you know, we're really saying to the provider, saying, you know what's best for this particular patient, and so, you know, we want you to be able to go ahead and do what you need to do for them. I mean, episodes in no way are trying to say that you can or can't provide that. It's basically just trying to say, you know, overall, it seems like this is perhaps, you know, some things you might want to consider when you treat this particular condition, and, you know, if you're doing what you need to be doing, then that's great. You know, you may qualify for some gain sharing, you may qualify for some risk sharing, but the idea here is really, in fact, like I said, in terms of taking the prior authorizations off a lot of these services, the idea is not to tell the physician what they can or can't do, it's rather support them in being able to manage their overall patient panel.
Yeah, I understand all that,
Okay.
and my last point, I just financially, we have to make financial decisions, and so that's, I'm trying to look at money in versus money out, and we've got to be able to account for that too on the back end, if there are complications from the result of that, and we've got to know those figures, that's all I'm asking.
Okay. We got another group I want to recognize back in the back. You all see some folks with some lab coats on back there. We've got some pharmacy students from Harding University. Would you all welcome them to the meeting today? I hope you continue down the field of pharmacy after what you did seeing here today. Senator Sanders, you're recognized for a question.
Yeah, thank you, Mr. Chair. On this, and I know we're going to get into sort of the cost of development and we've had I think a good outline of the potential savings. One of the things that I think has been missing, we look at it from sort of an Arkansas-centric point of view in terms of dollars spent. The truth is, when you look at what program this is under, the SIM program, the State Innovation Model Program, the grants that we're roughly had 17 states that federal commitment from 2012 to 14 and a little bit beyond of roughly $1 billion to work on these. The whole purpose of looking at accountable care organizations, the episodes, the patient-centered medical homes, the health homes, all those things were to allow states to experiment, to innovate, and I think one of the things that this isn't just for Arkansas. So Dr. Golden touched on it, the impact that we've already had on total hips and joint replacement, on Medicare, what the data that they've seen in real time here has impacted on a larger scale. So it's not, when Mr. Stephen comes up, we'll look at sort of the developmental cost, but that developmental cost, we're talking essentially less than 1/10 of 1% of total Medicaid spending nationwide. And that's the total grant program. That's not even talking about what we've spent. So if you could maybe give a little bit more perspective on the SIM grant program that this is funded out of, the commitment, the intent of the federal government to see if states can build a better box. And I think the assumption is that there will in fact be successes, there will be failures. And I think one of the things, we have had a lot of discussion in this task force about the federal government, our federal partners being displeased with, let's just say, the EEF procurement, displeased with other things. This, in fact, isn't one of those things that they're displeased with. In fact, it's one of the things that they're very excited about because they are looking at this in real time. And when you're able to show a potential savings on a total joint replacement, and as Dr. Golden said, some of those are making sure that the individuals going in for the assessment of whether or not is this really in your best interest, but they get the right outcome. So if you could put a point on that in a more global perspective, because I think we're very Arkansas-centric, and we're actually seeing some of the things that we're doing and the work that you've been doing. And look, you guys have been implementing a lot. You've had a lot of turnover. This is one of the things where we're seeing other states emulate what we're doing. And we're talking about federal dollars here, and we're talking about significant savings.
Absolutely, I think it's an important point. Certainly, Dr. Golden may have more to add. I think when you reference like the 17 states, when Arkansas started down this road, we were one of 5 states to get this federal grant to basically test and say, what makes sense, in the healthcare system, what can best, control costs, improve quality, and get the outcomes that we'd like to see. From that 5, they expanded to, almost 20. And I think it's interesting as you look at those proposals from all the other states, how many of them reference the things that we're doing here in Arkansas and saying, I want to do that too. I think that's a great opportunity for us to be able to look at, how we better, change behaviors, how we better, support efficiencies and bend the overall cost curve in the system. So I think certainly, what we're seeing in other states, the fact that, between Dr. Gould, myself, and others, it's at least once a month, we're getting invitations to come out and talk about what's happening, how we can help other states potentially design and inform what they're trying to do. I think the commitment from the federal government, as you've seen increasingly, particularly over the past few months, even coming from the Secretary of saying that, you know, by, you know, the time we get from 2 years from now to 5 years and then 7 years out, I mean, basically, they plan to be able to have all Medicare and eventually Medicaid spending inside of these kinds of value-based purchasing arrangements. Not necessarily saying everyone's going to do episodes, but to your point about, you know, this is all about trying to better change and improve and be able to bend the cost curve. I think the other piece, you know, besides looking at what's happening within Medicaid programs and Medicare, is even what's happening within, you know, other state systems. You know, I think at some point today we'll have a chance to hear from Bob Alexander about what impact this has had on the state employee system, which obviously, you know, includes many of the folks in this room. So, you know, I think the changes and the potential and the impact, you know, beyond Arkansas, particularly beyond Medicaid, I think are tremendous. And I think it's a good point and it's something that, you know, it would be important for us not to miss.
Before you get Dr. Lowe, the other point is true system engagement to get to multi-payers. And I've said this multiple times. You know, what I don't want long-term is a single-payer system. I want a multi-payer system that is based in consumer choice and consumer engagement. But one of the other things that you're to be applauded for is to, and the partners that are in the room, and I know Dr. Thompson's here as well, and S.E. Bowe, we're hearing from a lot of different people, bringing in the total, all the players. That is something that has not happened in other states. That is something that has really allowed the horsepower behind this to work. And I think that shouldn't be lost, because that is a very difficult proposition. Dr. Bowe, we've been talking about this with others from other states, and like, how did you get your insurance community, with insurance providers? How did you get your doctors involved? I mean, that is something that is in many instances unique to Arkansas, and other states are eager to try to learn from this experience.
Yeah, I think you mentioned nationwide is a real interest in going to value-based purchasing and doing it in a way that keeps the provider community engaged and delivering quality care. The fact that we're multi-payer, the fact that the multi-payer approach has, while each payer has their own unique attributes, we're using common metrics, common reporting styles, common sites of getting information to make it that each provider doesn't have to deal with 16 different programs, but a program with some commonality is a major attribute of what we've accomplished here in Arkansas. And as Dawn said, we get calls all the time now to talk to other states about what does it take. What is the communication, the collegiality we have with the other payers, the outreach we've done, the town halls, the communications we've done, the style and the approach. A lot of people are very interested and quite impressed to the scale that we've created over 3 or 4 years. So, you know, it's been an interesting journey. We're constantly learning. It can be better.
All right.
But it really is
All right. Representative Hammer, you're recognized for a question.
Thank you, Mr. Chair. I have a question about the diagram on page 11 about the emergency room visits per 1,000 beneficiaries. With the increasing number of places like MedExpress and other fast-track opportunities that would have otherwise been offered in the traditional ER setting, how are you factoring the beneficiaries that are going to those others, and how does that play into these numbers that you have?
We're going to be adjusting as we move forward. We are actually in active discussions with the medical homes as to how we want to deal with that, because technically they have to get referrals also to see those physicians. So this is a rapidly evolving area.
If somebody walks into the MedExpress place now, they have to have a referral from a physician before they can see that physician in that MedExpress?
In the Medicaid program, if you're not seeing a PCP, technically you need to have a referral or have that visit approved by your PCP. That's going to be, as I said, we are only now getting our hands around those dynamics.
So you don't know for sure. How long will it be before you know how that is actually going to impact these numbers that are being presented?
Or say substitution. I would have to, it would take us a while to do that. I'll give you maybe a few months for us to figure out what the substitution effect is.
All right, thank you.
One of the things, I'm just looking at our agenda, and on this topic C, we've got 9 bullet points of discussion, and we're currently on bullet point 1 and 2. So one of the things I would just encourage us to do is to let each person have an opportunity to share some, and that means getting some of the other folks up to the table. So I know there's a lot of interest in more questions, but if we could just try and get these off the board and let some other folks get to the table, I would really appreciate it.
Okay, we're gonna move on to the next bullet point. Thank you all for that testimony. You may be called back to answer some questions here that come up based on some of the things we hear. But the next one we've got on the agenda here is David Ruffin from the Medical Society. So David, if you come on down. Just state your name and you're recognized for your presentation.
We still on? Thank you. I'm David Roden with the Arkansas Medical Society, and it's a pleasure to speak with you all this morning. You've heard a lot of information, and I'm going to get inundated with it. And it seems like we can talk about it, so it's here today, and we can come back and talk about it 3 months from now, and believe it or not, we're asking the same questions a lot. And I don't know if it's because the answers aren't coming out clearly. I think it's because it's such a complicated, convoluted problem. Let me try to make my comment. I'm going to be brief, I hope, but there's some things I want to say. And let me first deal with the negatives. Those seem to be the ones that will make the paper the quickest. So let's deal with the negatives. Physicians are not unlike you. They don't like change. And we're living in an era right now where there is so much change in the healthcare system. And most of it seems to always fall on the shoulders of the physicians because they are the front line. They're the ones that see the patients day in and day out. If you just look back over the last few years, what physicians are having to deal with. We've got budget shortfalls in the Medicaid program. We've got skyrocketing health insurance premiums. We've got the federal government requiring electronic medical records, new coding systems. Well, this goes on and on. And every time something new comes along, it tends to cost physicians not just hundreds or even thousands, but sometimes hundreds of thousands of dollars to bring their offices in compliance. So, anytime you ask them a question about a particular thing that's going on, whether they like it or dislike it, it's with that backdrop that they answer that question.